So I'll be very quick in my slides because I want to emphasize more towards the surgical video which I will be sharing. So rest of the things are merely same repetition of the same issues which my previous speakers have already emphasized on, that a manual is small incision cataract surgery, which is a very popular technique among all of our cataract surgeons, is there for us to those patients in whom we cannot do phacoemulsification for various reasons. And it has been proven in literature as per few of publication, few of which are mine, that it is as painless as a topical phaco. And there are issues which should be taken care of, and the patient's experience is going to be wonderful. So the safety issue is all well known to all of us, that putting a needle in the orbit will have issues which Dr. Mohit and Dr. Navindu has handled well. And there's a glamour associated with this patch, but it looks only good on few of the individuals, rather not all of us. So the patient would be liking to avoid it, and this is possible only if the ocular movements and lid movements are well preserved. And it has been very well advertised that no injection surgery has a impact, as Dr. Navindu was telling. The patient's experience is a different one if he is not given local anesthesia. And how can we do this? So as with rest of the surgeries, you have to be good at it, because you cannot take chances in making a mistake. Communicate with the patient and remove that mind block that it is not possible. So I'm just repeating the statement that manual small incision surgery is possible under topical anesthesia. Now proceeding to how do we do that? So I have few tips of my own, although these are all individual variations and people can experiment upon. I use specifically lignocaine 2% jelly in place of drops, and I believe that it has a longer contact time and a deeper anesthesia plus prolonged anesthesia, as per the formulation allows the contact time to be longer than drops only. And I will advise minimal surface handling, because as Dr. Mohit said, the touch and pain may not be differentiated by few of our patients. And do use intracameral lignocaine in starting. If you have very averse to lignocaine putting any molecule in the anterior chamber, you may not use it later on, but starting may use it. Rather, there's a comparative study in phacoemulsification on use of no intracameral anesthesia versus intracameral anesthesia for phacoemulsification patients. And it was very conclusive that patients with intracameral anesthesia do have comfortable experience, because the possibility of stretching the globe and handling the iris is always there during phacoemulsification. I will advise against using bipolar cautery, because the current which causes a sensation which cannot be overcome by topical anesthesia. IOP rise and stretching of the globe should be avoided, and subconjunctival injections again cause some pain, so I usually avoid them. Now here we have a nice video where I'll show you. This is a recent video where you can see the surgeon has been planning a phacoemulsification in a very, very brown and hard cataract. And this is an initial shying away of the eye when intracameral anesthesia is injected, because the pH of the intracameral solution is little acidic. This is the formulation limitation, and it causes irritation of the iris. So patients will usually try to blink and have a protective reflex when you inject it. But over a period of time, the stinginess goes away, and now rhexis has been completed. And you will be surprised that I'm showing you a video of phacoemulsification, but just be patient and see. Now, during this phase, I realized that the bag is not very stable. So I decided to switch to manual small incision cataract surgery. And as you could guess, this patient was under topical anesthesia. A very, very light electrocautery is being used just to have control of the bleed. And the same incision of the phacoemulsification has been extended further to incorporate a small incision cataract surgery tunnel, and then enlarging the tunnel. So here I am able to also demonstrate that this is a useful technique. If you can actually have a situation where at some point of time you decide to switch to small incision cataract surgery, and if you are well versed with SICS and the topical anesthesia, you can do that. Now the rhexis is being extended because we need to deliver the nucleus, and you can see the nucleus is not very stable at the point. Now It's a large nucleus, it's a hard nucleus, and having unstable zone use adds to the trouble. Now, this is a situation where you will not like to experiment with FACO, so it was a good choice on my behalf that I switched to SICS. It's a large nucleus. Nucleus has been delivered by a Fish-hook technique. The IOL has been implanted, and you will see a twist here. Now, there's some cortex left behind because I decided to implant the IOL and then go ahead with the irrigation aspiration. This burst of bubbles, which you will see now in slow motion, suddenly cause some fluctuation in the chamber, and we have a PC rent right here in this area, and the vitreous starts prolapsing. So it becomes a special case where the surgeon, in spite of taking extra caution, was unable to avoid a posterior capsular tear. And because the IOL is in the place, I don't want to disturb that. So I am conservatively managing the vitreous strands and putting the air bubble in the chamber to stabilize and keep the vitreous away. So that was one surgery where I could demonstrate that you can have your desire of switching to small incision cataract surgery from phacoemulsification, given a situation where you decide to do so for safety reasons or any other reason. And even in spite of having a complication, I could finish the surgery. So I'll just add one more thing about intracameral anesthesia, which I routinely use. It has been very well demonstrated in studies that intracameral anesthesia not only helps in anesthetizing the iris and ciliary body, it also helps in sustaining the mydriasis. And it has been also known to help in floppy iris syndromes. So this is a great utility of topical anesthesia augmented with intracameral anesthesia. And as per various studies, putting 1% or 0.5% lignocaine in the anterior chamber doesn't cause any additional harm to the endothelium, which is supposedly one of the most fragile tissue in the eye. So this finishes my talk, and I am willing to take any question for whole of my team if there are any.